this lesson, we'll learn retinal vein occlusion. Retinal vein occlusion is an important cause of visual loss among adults throughout the world. It's the second most common cause of visual loss from retinal vascular disease, following diabetic retinopathy. The epidemiology, classification, clinical manifestations, diagnostic evaluation, and treatment of RVO will be discussed here. Epidemiology. The prevalence of RVO increases with age, is greater for BRVO than for CRVO, and varies by race but not by sex. In a pooled analysis of data from 15 studies conducted in the United States, Europe, Asia, and Australia, the estimated prevalence of BRVO was 2.8 per 1,000 in white and 3.5 in black, 5 points in Asian, and 6 points in Hispanic individuals. Prevalence of CRVO were 0.88 per 1,000 in white, 0.73 in black, 0.74 in Asian, and 1.0 in Hispanic individuals. Risk factors for RVO include older age, hypertension, diabetes, cardiovascular disease, smoking, hypercoagulable state, hyperlipidemia, glaucoma, retinal anterior abnormalities. Based on limited data, alcohol consumption, physical activity, and higher levels of high-density lipoprotein cholesterol may be protective factors for RVO. The classification of retinal vein occlusion is dependent on the anatomic location of the occlusion, which includes branch retinal vein occlusion, short for BRVO, and central retinal vein occlusion, short for CRVO, and hemorrhaginal vein occlusion, short for HRVO. CRVO occurs due to thrombus within the central retinal vein at the level of the laminal thrombus of the optic nerve, leading to involvement of the entire retina. BRVO occurs when the vein in the distal retinal vein system is occluded, leading to hemorrhage along the distribution of a small vessel of the retina. HRVO describes blockage of a vein that drains the superior or inferior hemiretina, leading to involvement of one half of the retina. Symptoms include visual field defects, blurred central vision. Patients with BRVO may be asymptomatic, but those with symptoms typically present with parahippal visual field defects. However, if the occlusion involves the macula, patients will complain of blurred central vision. Patients with CRVO usually complain of the acute onset of painless blurred vision in one eye. CRVO is seldom asymptomatic. Pain is notably absent because the retina has no trigeminal innerval. Patients with ischemic CRVO may go on to develop neurovascular glaucoma due to neurovascularization of the iris and/or the anterior chamber angle. These patients complain of a red, painful eye secondary to the elevated intraocular pressure, in addition to decreased vision. Findings on the eye examination. Visual acuity can be normal, but is more likely to be decreased, with greater potential for several visual loss in CRVO than in BRVO. Pupillary function is normal in BRVO, but in cases of non-perfused CRVO, there is typically an incipient relate afferent pupillary defect. Fundus include retinal hemorrhage, macular edema, dilated retinal venules, and cotton wool spots throughout the distribution of the affected vein. In CRVO, optic disc edema may occur. The classic appearance of CRVO has been termed blood and thunder fundus. The FFA allows quantification of the surface area of capillary non-perfusion. The CRVO study group established a perfusion classification scheme based on disc area that is now commonly used. A disc area represents the surface area of the optic nerve head. In this scheme, cases with less than 10 disc areas of capillary non-perfusion are classified as perfused CRVO, and cases with more than 10 disc areas of capillary non-perfusion are classified as non-perfused CRVO. Cases of CRVO where the extent of capillary non-perfusion cannot be determined due to extensive intraretinal hemorrhage are classified as indeterminate. The amount and the location of papillary non-perfusion in branch retinal vein occlusions is helpful to predict viral acuity and neurovascularization risk. OCT allows high-resolution cross-sectional imaging of the retina. It can qualify retinal thickening from internal field in areas of macular edema. OCT can then be used on follow-up visits to assess the progression of RVO or presence of treatment. The natural history of viral acuity after RVO varies based on the size and type of occlusion. Patients with BRVO unassociated with macular edema are commonly asymptomatic and usually do not experience loss of viral acuity. Patients with viral defects from macular edema may experience spontaneous vision improvement in the first few months after onset of symptoms due to resolution or improvement of the edema. However, after 3 months, the likelihood of simultaneous improvement in viral acuity demonstrates. 3-year viral acuity outcomes in untreated eyes with BRVO associated macular edema and viral acuity of 20/40 or worse at 3 months were as follows: 34% with viral acuity of 20/40 or better, 23% with viral acuity of 20/2000 or worse, and an average viral acuity of 20/70. Patients with CRVO has worse outcomes, with final viral acuity dependent on viral acuity at presentation. Complications of RVO can include macular edema, neurovascularization, and, less commonly, vitreous hemorrhage. In addition, as RVO may be a marker of underlying cardiovascular disease, it has been associated with future stroke and cardiovascular mortality in observational studies. Diagnostic evaluation. The diagnosis of retinal vein occlusion can be based presumptive on a characteristic history and findings on ophthalmologist examination. Eye examination. FFA is the definite test to confirm the diagnosis. It's usually performed at the in vitro evaluation. This study is also useful in identifying retinal capillary non-perfusion for purpose of determining the risk of neurovascularization and need for follow-up. Viral acuity, extraocular motility, intraocular pressure, pupillary function, external and internal structures of the eye, confrontation visual fields, slit lamp examination, and a dilated ophthalmoscope examination. OCT is also commonly used for monitoring macular edema from RVO. Differential diagnosis. Major considerations in the differential diagnosis of relatively sudden, painless, severe visual loss involving one eye are central or branch retinal artery occlusion, retinal detachment, ischemic optic neuropathy, and optic neuritis. Fundus finding of RVO can be similar to those of diabetic retinopathy, acute hypertensive retinopathy, ocular ischemic syndrome, retinal vasculitis, and viral retinitis, which can produce hemorrhages and whitish-gray retinal obstacle among the vascular arrests. Macular edema with hemorrhage can be caused by a variety of conditions, including choroidal neurovascularization, pseudoperic systematic macular edema, and diabetic retinopathy. Treatment is indicated in patients with RVO for macular edema, retinal neurovascularization, and anterior segment neurovascularization. Treatment also involves management of predisposing risk factors such as diabetes and hypertension. Intravitreal glucocorticoid therapy is considered an alternative for patients with edema refractory to anti-VEGF monotherapy. Gray laser photocoagulation therapy is another distant alternate for treatment for BRVO, but has limited, if any, benefit in patients with CRVO. Retinal neurovascularization. Scattered laser photocoagulation is recommended to reduce the risk of visual impairment from visual hemorrhage for established neurovascularization of the retina or optic disc due to RVO. In BRVO, scattered laser photocoagulation is usually applied to the potential of the retina in the distribution of the occluded vein where retina capillary non-perfusion most likely exists. In CRVO, pararetinal scatter laser retinal photocoagulation is applied throughout the fundus periphery. Anterior segment neurovascularization. Patients with established anterior segment neurovascularization are at risk of neurosecular glaucoma due to neuroscleralization that obstructs the trabecular muscle and produces synovial angle closure glaucoma. Intravitreal anti-VEGF therapy may be used as an adjunctive laser treatment. Surgical interventions is not considered as primary therapy given associated surgical risk and a lack of controlled trials showing benefit. We consider vitrectomy to be indicated for complications such as persistent vitreous hemorrhage or tract retinal detachment from severe neurovascularization despite laser photocoagulation and medical therapy. The key points include risk factors, classification, clinical manifestations, complications, diagnosis, treatment. Okay, that's all for this lesson. Thank you. See you next time.